Good afternoon, everyone. My name is Mike Schramm, and I'm Vice President of Sales for GetWellNetwork. The general session I'm here to introduce is very exciting for us, and I know it will be for you as well. To have so many nationally recognized leaders on one stage is special, and we're looking forward to hearing the insights that you share today. The focus of our panel is fundamental to the transformation of healthcare: how to lead change. Our nation's health system now demands even greater benefit and value from patient care. This shift calls for a new care delivery model to improve both the quality of care and organizational performance. But adopting a new care delivery model takes more than innovative technology. It takes leadership, commitment, and above all, behavioral change. We know that behavioral change is critical for patients to manage their health outside the hospital walls. But it's just as critical for the executives, clinicians, and staff within those four walls. The leaders on this stage have successfully managed change throughout their organizations, and we are fortunate to have them share their proven methods and strategies here today. With that said, I'd like to introduce our moderator of our panel, Dr. Monica Reed, Senior Vice President of Florida Hospital and CEO of Florida Hospital Celebration Health in Orlando, Florida. Dr. Reed has dedicated her career to promoting health and healing and is a leader in delivering patient-centered care. Please join me in welcoming Dr. Reed.
Good afternoon, everyone. Okay, you got to talk to me. There we go. Good afternoon. I want to thank Mike for that introduction, and certainly, as you well know, it's just a privilege to be here among 400 or more than 400 people really celebrating and wanting to know more about how we can do better for our patients. And I know with the collective expertise that we have on this panel today that we will all walk away with something different and unique as we hear. So let me just introduce formally our panelists, and I'll start at my far left, your right, with Captain Christy Grau, who is the Senior Nurse Executive of the Naval Medical Center in San Diego, and I know some of you visited there today. Next to her, we have Dr. Karen Drinkard, the Executive Director of the American Nurses Credentialing Center, Dr. Susan Stone, VP of Patient Care and the Chief Nursing Officer for Sharp Memorial Hospital, and I know we had a trip there today as well. And then give it up for my friend Dennis up here with all these women surrounded by all this power. Mr. Dennis Phillips is the Executive Vice President, Metro Group for Carolinas Healthcare System, and we're very, very thankful to have them here today. If we can go with the slides, great. I think you've known this story before. The patient saying, "Doctor, I want to choose how I'm treated." You're not just ill, you're deluded. And that physician, let's not, we don't want to talk too badly about physicians, but that really represents where healthcare has been for quite some time. Each one of us in the room as administrators, physicians, nurses, we've spent most of our lives with a philosophy in healthcare of what we will do to the patient, not with the patient. And we want, and patients want, their stories to be heard. We talk about educated consumers, but really, we live in a time where the patients actually want to be heard. So let's talk a little bit more about this dilemma that we find ourselves in. We have the healthcare team, and studies show that nurses spend about 30% of their time with the patient. So on a 12-hour shift, only about 30% of that time spent at the bedside. There have been some studies that have shown that physicians, an average patient load of about 20 patients, may spend a total of 85 minutes directly with the patient. That's less than 4 minutes per patient, and when it comes to the family, about 20 seconds. Is what some of the research shows. That's the world that we live in. And we live in a world where patients are telling their stories. Facebook, Twitter, all the social media. And as hospitals, many of us have developed this mass electronic system. We're connected in every single way, but we're still trying to figure out how we actually leverage all of this for the patient. Clay Christensen says, anyone who has been inside a modern hospital has noted myriad sophisticated technologies at work, yet healthcare seems to get more expensive and more inaccessible. The reason is that the purpose of most technologies, even radical breakthrough technology, is to sustain the functioning current system. So what we want to do is talk about how we deal with disruptive innovation. How do we make the radical changes that are necessary in healthcare, not just in terms of the clinical care, but also in terms of the patient experience? How do we make those changes become more disruptive in a good way and more accessible for patients? Now, many of you here are early adopters in this area, but there's a mass of hospitals all across the United States, physicians' offices, extended care facilities, where we're trying to figure out how we can do things differently and how we can leverage the current disruption that we experience. Why innovation fails is for many reasons. Some of these are not new to you. I'm sure most of them are not. But what we do know is that when we have disruptive technologies and we work with the same old business models and we make no cultural changes, that disruption is likely to fail. What you're doing with interactive patient care technology will become just another source of entertainment without a disruptive business model. And I think that's why many of us are here today. Then there are the reasons for success. What's making things work well? And again, these are common sense factors, if you will, in terms of innovation success. But what I really believe is that if we're going to be successful, it has to start with leadership. It must start with leadership. We want to make sure that we have a visible and committed senior leadership, and also that those leaders, that you are willing to take risks and see value in absurdity. Patients being empowered? Why, that's absurd. Are you willing to take risks with that absurdity? In many respects, leaders are conductors. We are conductors. We set the tone, the tempo, the tenor, and the pace for our environments. And we must see the symphony of innovation and the players that are in innovation, the people at your facilities, very, very differently. And we must drive an ecosystem and a culture that can adapt to these changes. Because without that, technology and disruption will rarely succeed. But are we ready for the ultimate disruption? Can we, in fact, pass the baton to the patient? Can we empower a patient in such a way where they actively are wanted to be involved in their care? All of us have a story, and if any of you have been a patient before, you know how uncomfortable it is to have someone else conducting everything around you. But we can learn to pass the baton. And that actually is the big, scary chasm in question. That is the big, scary chasm in question. I believe that the parts of our story that are irreconciled are where we can find our greatest sources of power and strength. That irreconciled difference between what we do to patients and what we do for patients versus what we do with patients and what we learn to empower them to do will be our greatest sources of power and strength. And we have a wonderful group of conductors with us here this afternoon. And so what I want to do is jump right in and ask our panel some questions that will help you as you conduct at your hospital and as you learn to actually have your patients conduct. So let's jump right in. And I'm going to ask this question to all of you, if you don't mind, and we'll start at the far end there with you, Captain Grau. Can you talk a little bit about being a high-performing organization and whether performance improvement is actually an active imperative for your organization and why? And we'll just actually ask all of you to respond to that in some way just to get you warmed up.
So I'll start out with performance improvement is an imperative at our hospital. We use it to operational or command focus goals of quality, healthcare, innovation, patient experience, and our commitment to staff. We do it, why? We do it for value. Our nursing staff and all of the performance improvements projects add value. It improves our quality of care, which really goes in hand with patient safety and patient experience improvements.
Thank you. Karen?
Thank you so much. Well, when I saw this question, I thought of that commercial that said, if you aren't whitening, you're yellowing. And so, I mean, if you ask inherently, like, is quality improvement important? If you're not improving, then arguably you're not getting better at anything. So for us at the American Nurses Credentialing Center, you can't imagine a sort of a bigger burden than us credentialing other people. So if we're not constantly improving ourselves, we really wouldn't have integrity in that process. So it's really our #1 priority, and part of our strategic goal is around operational excellence. And that entire foundation is our quality management system, which is really our operating system. So I just think it's really key. It's not a far leap at all to what it's really about, which is providing better care for the patient. So the short answer is yes.
I think we'll all remember that. If we are not whitening, we're yellowing. Okay. Thank you. Susan?
Yes, performance improvement, I think for any healthy healthcare system has to be an imperative. Our healthcare reform is requiring a level of excellence that none of us have seen before. If we are to survive and be a leader in the future, we need to embrace performance excellence as the standard of our business operation at every single level. At Sharp Healthcare, we began that journey 10 years ago with managers at the front line really having to be trained in change acceleration process and the basics of performance improvement, embracing evidence-based medicine, evidence-based research, and really being the front line of change and innovation. And I think in order to make it to the next level of healthcare reform, we just need to embrace that even more.
Absolutely. Dennis?
Well, I thought I was the only one who was going to have cliches, but I'll start it out the same way. And before I get to that, I'd say that I think indeed Carolina's healthcare system is a high-performing organization, but we're not high-performing in all areas. And because we're not high-performing in all areas, we absolutely have to be committed to performance improvement. There are many ways in which we do that. One once said that if you're not moving forward, you're moving backwards. I like the white and the yellow teeth better, but this one will work for today.
Smile on the way down.
The reality is, as we prepare ourselves for the change from where we are today to where we'll be tomorrow, healthcare reform, it's imperative for all the reasons that cost effectiveness, quality of care, that we have to find ways to do things better, and we're absolutely committed to doing that. Jim Collins said that good is the enemy of great, and we want to be a great organization. If we settle for where we are today, we'll be a good organization and not great. We believe so strongly about transformation or innovation and changing that our vision has now been set incorporating transformation. To be known for transformation is part of our vision statement, and I guess that pretty much says it all. Our responsibility is to be able to carry through and make it happen.
Dennis, let me just come back to you on that point. You talk about transformation being a part of your vision statement, which would imply in some respect that there's a lot of change going on in your organization. Can you talk about how you formally approach change management in your organization and what your typical organizational approach is, and what are some of those key success factors that help it to work so well?
Well, I'll be glad to, but Michael said I could yield the question to the next person over. No, in all seriousness, I'm probably the jokester up here. Let me just say that change management in our organization really equates many times to a change in the culture of our organization. Without top management endorsement of that change, whatever it might be, it's not going to go very far. But without carrying it completely through the ranks, it's definitely not going to go very far. We're organized as a system around 6 system goals: quality, customer service, performance excellence, employee engagement, growth, and community. And every year, of course, we're doing a plan that has action items in all those goals. But at the same time, we also, as an organization, develop priorities, things that are very important to us to reach those goals. And so those goals, those priorities are rolled into all senior management, in fact, all level of management in our organization's goals for the coming year. And that then gets it down to a point that ultimately it's fairly transparent to the unit level what we believe in, what we're going to get done, and what's important to our organization for the year as part of where we're going to get to. Goals are also, I guess, endorsed or vetted in another process with management, and they're driven through rollout process that include a management retreat where they're developed, they're fully vetted, endorsed, physician leadership conference where they're shared with physicians to get their buy-in, their tweaking of it so they're involved and know where we're going, and leadership development institutes, which are held quarterly in our organization, which bring about 1,800 middle managers together once a quarter, so it's vetted in that format as well. And then finally, that is transcended down to the facility or business unit management, where a president or a business unit manager will also carry those goals forward and changes forward in teammate forums. The key to all this, in my opinion, is accountability, known accountability. What is it we're trying to get done? Whose responsibility is it to get it done? And how are you going to be measured? Relative to key factors going forward, I think probably the most important thing is it's understood at the teammate level. What is the goal? Again, why is it important? What is the responsibility of each of the teammates to make that happen? And to get there, I think requires an environment where employees are truly treated and known as our most valuable asset, our teammates. And that's accomplished by a lot of ways: reward and recognition, making sure people are rewarded for doing the right thing and following the goals, hiring the right people to be part of that team so they have the attributes that are important to the organization, managers rounding with purpose and making sure people have the tools to do the job, and clear bilateral communication. And with that, if you get committed employees, then you've got something to work with. I'm happy to say that at Carolina's healthcare system, over the past few years, we've moved up rapidly in the employee engagement survey process and have last year finished at the 99th percentile as a system as measured by Moorhead and Associates. And so I guess when it comes down to it, if you think about it for a minute, understanding the change is the most difficult part. People don't like change. I don't like change. I get up in the morning and I have the same routine. If we didn't have the same routines, we wouldn't get to where we need to be on a regular basis without going nuts. But change is also important from time to time. And so what we have to do is make sure that we get our staff who are educated and understand the change, what it's for, what it's about. And we have the early adopters who jump in and they're ready to change anything in the world. They'll jump right on. You've got the great mass that's wait and see. I might be in, I might be out. This idea may make it, may not. But they come along, and then you've got the resistors. And the resistors are folks, frankly, you may turn a few of them around. And as an organization, we've learned more about resistors as we've matured as an organization, to the point where if you can't turn them around, you need to get them off the bus and get them on a bus that they can be successful somewhere else in their business career, because it's not going to be with us. So anyway, I'm going on for a little while here. I apologize, but it's important to make sure that we get those people off of our bus and onto the right one. Relative to what's worked for us, real quickly, productivity management, the change initiative there has been successful. To be candid and almost embarrassed to say this, we are an organization that historically has done fixed budgeting. And so if your budget to get the FTEs, by golly, that's what you were going to get, whether the volume went up or went down. And so our goal is to reposition CHS for success in a new healthcare reform era, and to move from a culture that is fixed budgeting to, quite frankly, variable staffing, which is appropriate in today's environment and gives value. The key to that is to make sure frontline managers understand the process, what it's about, they're educated, and they have buy-in to that. We've been successful, not totally successful at this point in time. Where we've been more successful, however, is patient satisfaction or customer satisfaction, and over the past 8 years, we have methodically moved forward to a point that we are, I think, pretty well hardwired amongst our organization in the area of customer service. We introduced the service excellence principles, we educated all of our employees, we monitor the metrics on a regular basis, and most importantly, we reward and celebrate that success. So, in summary, what hasn't worked is times that we've gotten ahead of our employees, times we've gotten ahead of education, times that we've tried to move without getting all of our teammates on board with us. And the other part is when we've had resistors that we haven't taken action with.
Very, very helpful. In the words of Walt Disney, success is not magical, it's methodical. And I think we heard a lot of that there in what you presented. Susan, let me ask you a question. Tell us about a significant shift or change you've made organizationally to address performance improvement, and what key lessons you learned from that effort that you feel you can use in hardwiring IPC in the practice at your facility.
There's a couple of things. I think that for Sharp Healthcare, we have been successful at adopting strategies outside of the healthcare system, such as the Malcolm Baldrige Award criteria, in order to really challenge ourselves, in order to really standardize some level of excellence consistency. We're really striving that we have an excellence level of performance every patient, every time, with every employee. And the Baldrige criteria have helped us. The Magnet criteria have helped us achieve nursing sensitive indicators and nursing excellence outcomes, as well as the patient-centered care excellence outcomes with the Plaintree organization. Yes. And I kind of think of them as the highway to success. Each of them are evidence-based approaches to achieving excellence, and if you can hardwire the structures and processes in those criteria, there's high likelihood, and what we have seen is that excellence outcomes are hardwired, reliable, and do consistently happen. And I think for us, the lessons that we've learned is the importance of the patient's voice and the level of employee engagement necessary for these to live over time. If we try as leaders to hardwire something ourselves and leave either of those two parties out, it will not be successful. We need to have our patients actively involved in the process improvement effort, hearing what our issues are in healthcare and being a part of the solution.
I heard you mention, you said Magnet, Baldrige, Plaintree. Talk a little bit, if you would, just about your organization's commitment to those types of journeys, if you will, and the focus that it's taken over the years. I'm sure it's plentiful.
It is. I think that what we have learned is that it stretches us. We started with stretch goals that we would consider applicable to healthcare, and when we started looking outside of healthcare at the Baldrige criteria, we were really intrigued by the fact that we could learn something from other industry, and when we applied that to healthcare, we saw a great movement forward. It's kind of like the pinwheel starts moving forward, and the same with the Magnet criteria. As we started looking at that and applying it to our business and how we were engaging our employees in collaborative governance, how we were having our patient advisory council be more purposeful when we applied the Plaintree principles and the criteria for excellence. All of those things, for us, our mission is to be the best place to work, practice medicine, and receive care. And if you use those three highways to success, it really does help you move forward in a purposeful way. Fantastic. It takes commitment. We did not add additional FTEs to manage that process. We as an organization have committed that our leaders and our employees will be moving those initiatives forward. And I think that's what really you need to do, is think creatively, as you said.
Right.
think of the absurd. If you thought of going after all three, you might just think that's absurd.
Right. Right.
But it is achievable if you just think differently.
Fantastic. Thank you so much. Captain Grau, how have you positioned IPC in your organization to stimulate the adoption needed for this new approach to care delivery? And maybe you can talk a little bit about the key lessons that you've learned and what you've put in place to support the adoption.
So we started with the executive oversight with our ESC, our Executive Steering Committee, and then because the GetWell system is very nursing-centric and nurses spend the most of the time at the bedside, we really felt that it would sit best within our Executive Committee of Nursing Staff. And from there, we have subcommittees we've developed that we'll look at our nursing practice, look at our policies, and implement that into our everyday practice. As far as key lessons learned, probably the most important lesson is that it really takes a team approach to implement the system consistently on every unit. We developed an IPC team, program managers, so we have a dedicated staff that work on the implementation and utilization daily. We also identified patient educators and champions. They work side by side with our nursing staff just to help introduce the interactive patient care model and really how you use the technology into the nurse's workflow every day. Another thing is just listen to the nursing staff that are using the system. What is working and what is not. Knowing when to back off and not push another initiative. Before you really perfect what you're working on. We all have competing initiatives, and it really was an everyday campaign to not only push IPC as the most important initiative for nursing staff, always keep that at the top of the list. And you know, there's so much information, not just on IPC, but all kinds of regulation information that's rolling out that we're all trying to keep up on top. Especially we have Joint Commission that's expecting in the summertime. And so sometimes we have to translate for our staff priorities and really what should we focus our efforts on. So we did hold back on some functionality that I wanted to push forward, but felt like our nursing staff just wasn't quite ready for that. And then I think one other thing that is particular with Department of Defense is that we have so many initiatives that we roll out, and then we don't have anybody to it's rolled out to the end users, but then and we expect the nurses and the physicians to implement it without providing the resources our staff to support, not just the implementation, but long-term adoption and cultural change. And I think probably the third thing would be to really pace yourself. We definitely, like I said, pushed back on implementation of the pain pathway. You know, despite fragmented implementation, our technology is only on 5 of our 17 units. We are continuing to realize the value daily of the system. Other units hear about the system and they want to jump on board.
That's fantastic. I think pace is very important, and we experience the same thing in our organization in terms of slowing down so that you can have the key folk, who are the nurses, quite honestly, being involved. So, Karen, you've heard nursing, 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 nursing. Comment, if you will, on the role of the nurse as it relates to IPC and the transformation of that nursing role, if you will, and what guidance you think you can offer to help motivate, interest, gain, sustain support for the nursing staff as it relates to IPC.
Thank you. Thanks, Monica. Well, you know, really, if you think about the center of the relationship between the patient, the nurse is really the primary person that's there 24/7. It's not to say that it's not a team sport, because it actually completely is, but the relationship with the nurse is really fundamental. But I also think there's another relationship that has to be tended to at the exact same time, which is the relationship of the leader with the clinicians. So if you keep those two thoughts in mind, for the nursing role, you know, we are seeing an increasingly educated nursing workforce and really moving towards knowledge work. And the nurse as a role of a synthesizer of data as opposed to a tactician. So that's a key thing that you really need to keep track of, because if your nurses are acting as tacticians, and this is embodied by more attention to the clipboards that they're carrying around than to the integration of the data that they're doing. And I also think we need to think about the role characteristics that they need. And there's a great book called Innovate Like Edison, and it says the leaders of work, not formal leaders, so I'm not talking about who's your boss, I'm talking about leadership and patient care, have to have some characteristics that are different than what we had in the past. And one of them is being a mastermind collaborator. Another is having a solution-centered mindset. So coming at things from a solution center as opposed to problem identifier. And for the folks that are clinicians in the room, if you think about how we were educated as scientists, which is all around problem identification, right? So we're really good at pointing out what's wrong. And so that shift to what's right and what's a solution is a big transformation that needs to happen. And the other that they talk about is having role clarity around coordinating the intersect. And if you think about what's happening with healthcare reform and accountable care organizations and where the patient's journey is, they don't live in the hospitals. I mean, they just absolutely don't. That is a blip in their care. So coordinating the intersect. So if I take you back to what is the relationship between the nurse and the follower, as a follower with the leader, whether that's a nurse leader or another leader, I just want to ask you, like, what percentage of the time do you think that the followers are watching you as a leader? Like, just a guess. So if you guessed anything less than 100% of the time, they're watching 100% of the time. So whatever your leadership role is, so I'm talking in nursing from charge nurse above, you're being watched. So here's what's free and here's what's completely within your control: attitude and enthusiasm. So attitude's free. If you have a negative attitude, it's easily contagious. If you have a positive attitude, it's equally contagious. And that's the same thing with enthusiasm. So everything that you heard about, being a champion and being out there and being engaged, they follow what you follow. So if you're following these pieces of work, they're going to watch and see what you pay attention to. And sometimes that's as simple as making rounds and saying, so what's going right today about this? And then that'll frame that as well. So, from a tactical perspective, tapping people who you think have that enthusiastic spirit, even if they don't yet have all of the knowledge that they need, because you can teach them that, and you can't always teach the positive attitude. And then also I would suggest that we need to put some structures in place, and with the shared governance councils that, for example, Magnet requires, that's just creating a place for people to do the work that are at the point of service, and they know what to do anyway. So when I was a chief nurse, I said my biggest role was really just finding the money to order the lunch, because once I got them in the room, it wasn't about me helping them figure out what to do, it was them figuring out what to do and me just creating that space for them to be there. So that's sort of some suggestions.
Very, very good. Dennis, how aligned is IPC with your organization's strategic plan, and how do you plan on keeping that an imperative for your organization?
Well, first of all, let me say that as an organization, we're probably a full continuum full of services, from about 2,000 employed physicians through acute care, nursing homes, urgent care centers, you name it, we pretty much have it. And as we move forward, our goals really are centered around how, as an organization, we are going to address healthcare reform, how we will create value, how we will be better than we have been in the past, and how we will meet the needs of patients moving forward. It's almost, in some ways, disheartening to me, since my role is more acute care than anything else, to think in the future we're going to be much more and more limited, but that's a good thing. That's good for patients as we move forward. When you look at it, IPC really is identified as a key enabler in our efforts to have patients and their families take an active role in the patient's healthcare experience, no matter where it happens in our system, and also their health status. We believe IPC is critical at all levels of our healthcare continuum. Although GetWell doesn't go to all levels at this point in time, it's more concentrated in acute care. We're optimistic that there will be great changes along the way where GetWell or some version of GetWell will be in the medical home, the primary care offices. It will be in the specialist offices and aiding in the teaching process, if nothing else, with our patients as they flow between those two providers. Also, the acute care setting, which there's a great foothold right now, obviously, with GetWell and IPC, rehab, post-acute care services, continuing care, and even to the area of palliative care or hospice. So basically, I think it's a key enabler for us moving forward and absolutely tied to our strategies moving forward.
Fantastic. Very, very good. Maybe you can talk, Dennis, just a little bit, and Captain Grau, I invite you to speak on this as well, and certainly if any of our panelists have any other comments to make, you can just kind of weigh in here. But what advice do you have to garner consistent leadership engagement and support and attention for IPC? We talked a little bit about all of the initiatives that we have internally, the external regulations that are upon us. How do you keep methodically keep your leadership teams, and Susan, I invite you to comment as well, engaged and keep their attention focused on this very new and disruptive technology?
Well, I would say that from our organization, it's housed as a priority in a multidisciplinary executive team, which includes representatives from nursing, from IT, from patient experience, corporate quality, physician leadership, etc. And it's a very highly engaged group that works in this area. And they embraced IPC as absolutely critical to what we need to do to provide services to the patient in a better way going forward and to make the outcomes for patients better. This stays alive as we implement various forms of IPC within our organization. And basically, it will stay as a priority in our organization until we get there.
Good. Now, how often does that team meet at your facility?
Monthly.
Okay, so it's a monthly meeting. Captain Grau?
So I really believe that the CEO and CNO need to believe in the product and be able to speak to staff about why you think your system and patients could benefit from IPC. Translate what you are trying to say. One of the things that I think was helpful and successful is that I would go to the individual units and talk about my experience working as a nurse practitioner, working with adolescents with diabetes, and how telling patients what they should do was not working. Mm-hmm. And really realizing that we really do need to engage patients to find out what does work for that adolescent patient. What time can they check their blood sugar? What time do they eat their meals? And I think that just trying to translate that and about what patient engagement looks like will help your staff.
Okay. All right, and do you have a set organizational structure for that to happen in?
Well, we have this, which is a work in progress, and you can see how there's I have scribbles all over it. We're pretty early in our journey. Definitely, this is really our structure. Okay. So we're still working out all the little idiosyncrasies of responsibilities and where the program will sit. But again, one of our most successful strategies has been putting dedicated resources to oversee the system and keep it together as a program, rather than just rolling it out on the units.
Susan, I see you nodding. I'm going to invite you to kind of comment on that as well.
It's critical to keep it in front. As we roll out the system to our other SHARP hospitals, we've got a steering committee that includes top leadership from each of the entities to agree on standardization of content as well as measure the return on the investment. At the entity level, we've engaged our patient advisors in helping us to make the product more meaningful to our patients, as well as our frontline staff. We have that topic actually on our Safe Patient Mobilization Committee, where they're extending the use of IPC to help patients be safe and prevent falls. We have it engaged in our Patient Education Council, and all of those efforts are involving our program manager for innovation, and she really leads the effort to make sure the technology is deployed in a meaningful way, and that we're consistently engaging our frontline champions for GetWellNetwork. Every unit has champions. And I will give them some great applause because they did a great job this afternoon really teaching our community of GetWellNetwork visitors how to use the system. And they are really the front line to help us make sure that we as leaders are doing what we can to remove barriers that they're experiencing and to make sure we're moving the product forward in an innovative and meaningful way for them and their patients.
Okay. So at your facilities, and again, just inviting the three of you to comment on this, where does the responsibility for IPC reside? With whom? Is there one person, or do you have a committee that's overlooking it, or where would you say is there a point person that says this is my focus or my accountability? We talked about accountability on a regular basis. How does that work at your facilities?
Well, I mentioned earlier that we have a multidisciplinary committee or group that meets on a monthly basis, and it's one of the it falls under one of the priorities for the system. That we have for the year, and we'll have probably ad infinitum. The reality is that there's good representation across organization, and there is a commitment from all involved to make sure that we move forward and don't lose pace. We've involved people in the implementation of the Get Well project. We have 2 hospitals right now that are part of that. Caroline's Medical Center, which is our almost 1,000-bed tertiary facility, tertiary quaternary facility, and then Levine Children's Hospital.
Okay.
So we've had obviously a great workforce and committee involvement there. But we also, because we hope to, based on successful implementation, to roll this out to 7 other metro facilities in the next year or so, we've involved leadership from those organizations, those facilities as well, so that in fact they're prepared and bought into where we're going. It's been, I guess, absolutely fulfilling and refreshing to see the leadership step to the table in that process. Nursing leadership, both of those 2 facilities, the chief nurse executives, as well as our chief nurse executive for the system, who's taken an absolutely large lead role in this as well. In fact, she's here. Y'all may want to see her. Mary Ann is here with us today as well, and for the meeting. I think that there's been specific examples of how it's worked out well when we have the chief nurse executive at CMC, for instance, attend every meeting of the pain pathway to make sure as they develop that she's involved and she gives credence and support to that. Same thing's true at the nurse manager or nurse executive for Levine Children's was involved at almost every communication point that she could be in supporting this moving forward. So I guess the real key is to have the support of management and to involve as many people as we can in this. It's the last thing I'd say is we had 60 people, I guess, on the original group that put this together. That's a lot to come up with any kind of consensus, but it's a great base to have consensus moving forward. And so the effort to make that happen is well worth it. It's spread it in organization.
Fantastic. Captain Grau, on your organizational chart that you have there, are you thinking to have a senior level steering committee, and do you have a point person? How does that work at your facility?
So we do have our senior level committee, which is called ECONS, the Executive Committee of Nursing Staff, which is comprised of senior nurse leaders of every specialty at our hospital. And then from that, we have 4 different subcommittees, professional practice, a junior group of nursing staff, both civilians and military, that really kind of fall into our interactive patient care innovations, nursing clinical quality, and clinical practice. And what we found is that under clinical practice, all the same people were going to the same meetings. Or they were all going to meetings, and so under clinical practice, we have evidence-based practice projects, informatics, policy and guidelines, and then competencies. Wow. Because everything is connected. And under our IPC manager is where we have the resource staff, and they're connected to informatics. And we're still working on feedback loops, reviewing dashboards, getting the information back to the staff and to the leadership teams.
I think what we're hearing is that there is a structure in the organizations to really make this endemic to the culture. And that doesn't happen easily. And it sounds like, especially in what you just described, that at every level of the organization you have involvement. And I think that's a common theme that we're hearing today.
We spent a lot of time really trying to figure out how IPC would fit into our organization. Mm-hmm. And I don't think that the right place is in IT, or just because it is so nursing centric. I think that it's been very helpful for us to strategize. And although we've realized and we've changed strategy, mm-hmm. we did a lot of our initial rollouts with all senior nursing leaders, and finding out a couple months into the rollout that we really didn't get deck plate feedback about what would work and what wouldn't work.
Okay.
And we've kind of relooked at that strategy.
Fantastic, thank you. Susan, as you well know, Sharp is known for the Sharp experience. Maybe you can talk a little bit about the Sharp experience for those who didn't have the opportunity today to go on the tour, and talk about how its role in your competitive strategy and how that actually has integrated into your IPC approach.
Certainly. The Sharp experience was really the efforts as a result of wanting to move from good to great. That started in the year 2000, where our organization started doing multiple focus groups, talking with our employees, our physicians, and our patients about what we should and could be doing differently to really create an exemplary experience. In order for our organization to be viable and healthy and innovative going forward, we knew that we needed to do something to differentiate ourselves in the market. Okay. And we created a cultural transformation really from the inside out that empowers, engages, and activates our employees, our patients, our physicians, volunteers, and families to really be a part of the care experience. We work every day to personalize and humanize that experience so that it is meaningful to every single person, and every person has a different expectation with their interaction with us. But we really are moving in the direction of customizing that care. IPC is a key strategy for us with that. Some of the things that we do at our facility is, upon admission, they see a welcome video through the GetWellNetwork that welcomes them to our hospital and shares with them a little bit about the experience they're about to take part in. They're invited to have a family member be a part of the care team. And I introduced that concept as the chief nurse, inviting them to speak up, be a part of the care team. We want their families to stay with them. And I think that's critical for us to set the stage, that it's not the medical team providing care to the patient. They really are the team leader that is driving us in a meaningful way to provide them health care. And for us, that has been very helpful to consistently go back to the voice of the customer, employees, physicians, and patients to see how we need to continue to move forward. Our IPC system was really tailored by the voice of the patient.
Okay. We
had a patient on our team that went back to the home office of GetWell, met with Michael and the team, and our IT folks were there with us. She chose the keyboard that the patients would be using. She told us what she wanted the patients, what would be meaningful to them. And I think that's helped us in the deployment of the process, was really embedding the patient's voice at every single level.
That's great. Fantastic. IPC, Karen, is new and different. It is, to keep things in line, it may be an absurd way, if you will, compared to the way most of America does healthcare, to think about how we would deliver patient care using this type of interaction. Can you talk a little bit about how we should go about, or what we should be thinking about, in creating an accountable leadership structure for integrating this model at the bedside? How would we do that, and how do we get it done from the nurse executive straight down to the front end nurse who's there, and we know telling us that I only have about 30% of my time dedicated to the patient. How do we kind of reconcile all of that, and what would be your recommendations?
Well, I really loved what Captain Grau was saying about figuring out how to get organized, and I think you have to, with any big change management, you have to be using tools like project work plans, and you have to be using accountability grids, and you have to be really clear on who's in charge of what. But what I think can happen sometimes with big initiatives, especially when they involve a technology product, is you do run the risk of becoming the flavor of the week. And when I was a chief nurse, I actually had nurses that would say to me, I can wait this out. Mm-hmm. I can wait you out. Mm-hmm. And by the way, they say, I'm on the night shift, so I don't have to see you.
That's right.
They love it when you work on the night shift because they have to see you. But so one thing I did was, because I knew I wasn't going to get out of the room without talking just a little bit about what magnet might bring. Mm-hmm. So I don't really care if I do care, but I'm just going to say for this, if you're magnet or not magnet or on the journey, just take a look at the manual, because it's a roadmap for some things. And if what I did is just went through some of the it's evidence-based, what the component pieces are that you need to think about. So under transformational leadership, you need to think about strategic planning. So if this is not on your nursing strategy, it's not going to make it, because that really should guide everything you do. And if it's not on your organization strategy, if you're a nurse in the room, you're going to have a hard time getting what you need. So that strategy has to be aligned. There's standards around advocacy and influence from a leadership perspective. So those are really key, I think, role sets, advocacy and influence. And then there's standards around visibility, accessibility, and communication. So I would just say any effort this large is not something that can be done from your office through email. It's just not possible. And you have to attend to your email, but that is not the way that these are sustainable. These kind of efforts are sustainable. Then just, I'm doing some work with CUSIN, and one of the competencies is patient-centered care, and we have a lot of barriers to people wanting to give up control around what patient engagement and patient-centered care. And the reason is because clinicians are good at telling other people what to do, because they think they know what to tell people to do. And so when you have to give that up, that's a control piece. So just giving some thought to that. There's a leadership requirement that says to give an example. So anytime if you're even thinking of, if you're on the magnet journey, or you look at that and say, could this be used as an example? Because then you can leverage that by saying it's not an add-on. Because you don't want IPC to be an add-on. You don't want your magnet or Baldrige journey to be an add-on. Because as soon as it's an add-on, it's at risk of being an add-off, if you know what I mean. Okay, I've seen Post-it notes get moved to the parking lot. And you're like, oh my God, there just went my entire nursing division strategy for the next 3 years. And it's on a parking lot if you're not integrated. So here's an example. Give an example of changes in the work environment and patient care based on input from direct care nurses. So you can use this as an example of that, how nurse leaders use input from clinicians to improve the work environment and patient care. And then in a care delivery system, how do you involve patient and support systems in planning and delivery of care? And probably some of the best examples I've seen is organizations that actually put patients on their advisory councils and their patient care councils to tell them what was the patient experience really like. Because if we're just sitting around as clinicians sort of thinking what the patients want or need, then we've just violated the whole first thing around giving patients that control. And the thing is, sometimes what they want is maybe not what is convenient for us, but that's what they need. So we have to kind of lay those pieces down. I think clearly you have to get organized. There's a lot of different approaches and ways you can do it, but the more you can integrate, I often said to my nurse managers that their jobs were to be funnels, and that everything that we had and that we were responsible for got poured in, and they had to be the integrators of it so that the clinicians at the bedside and the patients saw one seamless care process and not every day something different and every day something fragmented. So if you think of that role as integrator, if you think of setting up your system so you can be integrated, I think that'll give you the best competitive advantage for success and sustainability.
So many questions are going through my mind right now based on your comments, but just talk about just a little bit more about the role of the nurse as the funnel, because I think, you know, I don't think my hospital is unique in this, where nurses feel like they have more and more pouring into that funnel in terms of the role that they're playing for, you know, between the doctors, with the patients, with the family, the charting they have to do, the compliance rules, and they're saying my funnel is so full. What are your thoughts on that as relates to the role of the nurse and how we keep that funnel manageable, but yet still are true to the principle that, yes, they are that funnel, and we do want them to integrate that information?
Yeah, so, I mean, just this is my opinion, but I love crosswalks as just a tool. And the more crosswalks you can do with the 47 initiatives that you have going on, and then the other thing is, okay, so like anybody who's in grad school, did you ever use one paper for more than one class? Because you'd already done the lit review? Okay, if you think about all the efforts that you're working on, it's the same lit review, right? So sequential papers, integrated papers, papers that build on each other. Instead of, I think one of the most easy way to fail is if everything is separate, then you're competing for resources for your project. If everything is integrated, I've often thought if we just took a blank piece of paper and an empty unit and started over, how would we design the care process? And I don't think we do enough of that. I think some of the best work I saw is at Mass General. They're creating innovation units, and they're trying to start from scratch on some things, and they're giving freedom to the clinicians to say, how would you design this if you were designing it from the beginning?
Yes.
But that piece of overload and too much, I think the root cause of that is because everything is a separate responsibility. And I have hope that the integrated IT systems are going to help us with that. But if we just take what we had on paper and put it into the computer, we'll still have the same issues.
Absolutely. Absolutely.
So I think that's the opportunity that we have right now. It's a very exciting time.
Yeah, that's good. You know, and I saw many of the panelists nodding their heads as you talked about crosswalking some of those initiatives and making sure that they blend. Susan, can you talk a little bit about how you're measuring the success of your IPC strategy? I have no doubt, given what you've talked about, that you do have measures for success to know that you're moving from good to great. And how do you make changes based on the outcomes that you're seeing?
Well, one of the great things about this project was to set out the return on investment measurements ahead of time. So we worked with our implementation crew to identify the key elements of the HCAP survey that we were going to be targeting. We looked at our data to target the lower scoring questions such as medication side effects, the discharge process, some of the questions on that composite. We also targeted some of the nursing sensitive indicators that we needed to improve, such as falls. And then we wanted to use the discharge pathway to reduce our length of stay. So overall, those were the key things that we wanted to target when we went live. And we have seen dramatic improvement. Our talk box scores for the HCAPs overall is 7% increase. I will say that we have very, very good patient satisfaction scores. We have for the last 3.5 years been over the 90th percentile and most of the time over the 95th. But still, we are striving to push the envelope to get even better. For our falls, which was one of the key measures, we've reduced our falls by 30%.
Fantastic.
Now, this is not the one-point strategy. We have a team that built actually additional strategies around that that have helped us dramatically. We've also decreased our length of stay by 5.8%. And again, that's not just this strategy of the discharge pathway, but it's case managers and our doctors working together in collaboration with the discharge pathway information, and then our medication side effects pathway for the top box scores, we're 75% increase on that measure with HCAHPS.
That's great.
And again, we used this as well as teaching cards that we gave to the patient to reinforce what they saw on the GetWellNetwork TV. But I think that for us, it was very important to identify those things that would really bring value back to the organization, such as the hospital-acquired conditions and our HCAHPS scores.
So it sounds like you set out at the beginning what it was you wanted to accomplish, and then to maybe add in what Karen's comment was, making sure that your other processes were folding into that and it wasn't set aside as a standalone project.
Absolutely, and how did we tweak it when we weren't seeing what we needed? A good example would be the self-assessment for falls. One of the things that our manager of innovation and performance improvement identified was that it was the younger folks who were not identifying themselves as a fall, who were getting up. And so having those patients go through a fall assessment 4 hours after admission, everybody does that. And then the score is calculated and it acknowledges based on their own information that they're at risk for fall. And that changes their perspective. It's not just the nurse who's saying, you know, you're in the hospital and you're at risk for fall. It's really them
Putting it back.
Learning about it.
Excellent. Captain Grau, any comments on that?
So I'm not going to give you the traditional answer.
Okay, good.
Our doctors know about it. So I think that what we've done is every time that our staff is out, department heads, myself, we talk about the GetWellNetwork system, and I ask them. And they do know about it. Our comptroller knows about it. Our lawyers know about it. We have pharmacy calling our program managers to see if they can be part of the system. So I think that you know, we have not set up our return on investment. You know, we're the Navy. We've had a blank check for the last 10 years. So so our world suddenly changed with sequestration.
Yes.
And so I think our reality now is to go back. Our executive leaders do know about GetWellNetwork and IPC adoption. Our admiral speaks about it in our leadership team meetings. So now, and we have had early successes. We just received we have TRICARE inpatient satisfaction surveys, and we just received our first quarter fiscal year, and we were about 13% higher on our top composites of overall rating and 13% on staff responsiveness. So really those early successes have garnered attention, not only at our local facility, but also at our higher headquarters, BUMED. So we've surged ahead of all of our patient satisfaction scores as compared to our sister sites as Walter Reed National Naval Medical Center and Portsmouth. So, you know, taking that and then going back and looking at our return on investment and being able to speak to that, the value of the system and why we need to keep GetWell to keep competitive. Fantastic.
I want to ask a follow-up question to the panelists, and it has to do with what you said initially, which is your physicians know about it. Let's talk a little bit, if you could, comment on the role of the physicians in your implementation and in your strategy. Are they people that we benignly, why would I choose to say that word? Do we pay attention to them in this strategy? Are they important at all, or do you feel that, you know, they'll come along and whatever they need we'll kind of figure out? Where does the physician fit in all of this?
So initially when we developed our IPC vision, we had multidisciplinary teams that, including physicians, and probably the biggest part that they've played in is reviewing our video content.
Okay.
And that was kind of a big deal because it was like they were letting something that was really close hold, and they didn't want to, like we were making all these decisions without their input. And I think once they realized the value and the how good these videos were made and that the content has already been vetted, there was really nothing else to add.
Fantastic.
And so it was really just a stamp of approval. But now it's engaging them in discharge videos. That's probably one of our, where we're getting the most feedback and where they want to be part of this system, where they want to do their own videos. Our orthopedic surgeons want, you know, it's very, I think it's very powerful to have the orthopedic surgeon be able to have the video. It's difficult to coordinate with the family when they're at the bedside sometime, and so you can go ahead and have that video with the surgeon talking about his discharge expectations, and then he can pop in after he's done with, been in the OR all day, and just talk, you know, touch base with the family and see if they have any questions. But other family members can also have that opportunity to see those videos. So I think they see the value in that, and we're just beginning.
Good, fantastic. Susan, Dennis, comments regarding your physicians?
I think initially ours was the same, where they had input into the video content and were giving us feedback about what they support, endorsed, and were concerned about. With our electronic whiteboard that we've been working with, it's an opportunity for them to hear from the patients directly. The patients can enter their questions. When they do rounds, we've been teaching them to go and activate the whiteboard so they can review the information with the patient, so that it's a more real-time, I call it an open medical record in a sense.
Absolutely.
So that they're having that purposeful conversation right then during their rounds with the nurse, handing off shift to shift, that sort of thing. And I think it's taking it to the next level for them.
Okay, good.
And I would just comment from a perspective, last summer in August we had the physician leadership retreat or conference, and we had physicians from all the owned obligated you know, facilities within Carolina's healthcare system. Michael came to our meeting and presented GetWellNetwork, and the biggest outcome of that is I had to beat back the doctors who were saying, I wanted my hospital next or first, and so if that's any indication of things to come.
That just means Michael did a really good sales job.
Well, he does that too.
No, that's very good. Karen, any, from a magnet perspective, talk a little bit about how you view the nurse-physician relationship and how you see that fitting in, because I know you have an opinion on this.
Well, I mean, it's critical because I think the future direction is going to be about interprofessional collaboration. So it's going to be critical that we kind of get our act together as the team so that we're really fully informing the patient so they can decide and make decisions based on what the whole team is recommending to them. So I think these are really great strategies. And then I just wanted to add one thing about the measurement. I just think you need to measure everything and then take credit for what goes well, because just like Susan was saying, there's lots of multiple things that we're trying to improve at the same time. So to the best of your ability, don't forget to measure before you start making changes, because otherwise you'll come to the place where you say, well, what difference did it make? And you really won't be able to figure that out very easily. If you measure ahead of time, or at least look to what the measurement was and then look at afterwards, you can at least say this had a contribution to this, so we really need to consider keeping these pieces, because you may end up with the magic kind of bundle of things that will improve, because outcomes like that are really substantially what everyone's trying to get to.
We only have about 5 to 6 minutes actually left. So with the remaining time, I just want to ask our panel, each panel member, to, if you only had one thing that you could tell our group of conductors here about what they need to do to accelerate patient-centered care, interactive patient care, however you look at it, patient activation, what would be your recommendation to this group in terms of how to actually get that done? And if you want to sneak another comment in there, you can do that as well.
Do you have an order? I
don't have an order. Whoever feels most enthusiastic about it and has the right attitude can answer first. No, please, go ahead, Dennis. Since you started commenting, go ahead.
Well, it seems to me that the best way to move forward and with as much support and as rapidly as possible is to be able to demonstrate value. And value to all the multiple constituencies that are affected by having IPC. You know, first and foremost, our teammates. you know, whether that's nursing or ancillary departments or support departments. How does this make a difference? And I assure you that it makes a difference. I hear it already, and we're infantile in our experiences here compared to most of you out in this room and the audience. I think to be able to show at the senior level that it makes a difference. You heard numbers quoted, you know, from Sharp, you know, when how it affected their patient satisfaction, how it's affected, you know, probably their losses and lawsuits and those types of things. Reduction in falls, to be able to have demonstrable evidence that it will make a difference. And it doesn't just make the bedside nursing tougher. It makes it easier, or at least doesn't make it any harder, but it's very rewarding. And I guess last but not least, to say the least, is that the value demonstrated to patients as they truly understand how to care for themselves on discharge orders, as they have a way to interact, and we know how their pain level is, as they have a way to evaluate the fall potential and be educated there. And I'll just anecdotally close with, I sat in meetings that talked about discharges from our hospital system, and talked about, and we did some filming of things, and I wish I had enough papers here, but I'll take all these and this, and if I could have yours too. And the nurse coming and say, it's time for you, you're going home. Here, you'll need this stuff.
Exactly.
You know, be sure you look at it when you get home, which of course they followed the patient home in doing this type of study. And they got to the patient's home, and that stack was right there on the kitchen table, just in case they ever thought to look at it. But it was daunting, and of course they didn't. The reality is we owe it to our patients to make it as good for them as we can, to give them the best chance as they go home to stay well, live well, and improve their health status. And I think that those are the reasons to do this.
Fantastic. Thank you. Susan?
For us, the key things I think that we needed to consider going forward is identify all the key stakeholders and make sure that they're aware and involved. Find out what's important to them and make sure that you're including that. Identify your measures of success early. It's critical for you. Involve your key customers in the decision-making process, patients, the frontline staff, the people who are going to be using it day to day, and the doctors. And then the key thing I think that really keeps it moving is tell the story.
Yes.
Gather those comments through the GetWell system and tell them a lot and often. Tell the story of your frontline staff and how they're using the system, because it's the story that makes the difference. And we can quote numbers, but in the end, when we can share the story of a patient where this made a difference in their lives, that's what's most important.
Fantastic. Thank you. Karen?
Well, I mean, I think getting organized and being clear on the assignments is critical. And I think that you need to really think about how you're recognizing risk takers, because sometimes we don't always recognize them. So we have to give them a safe place to try new things. And then lastly, I would just say this takes tenacity. So my comments about enthusiasm and attitude are, you know, you have to stay in the game, and you have to have some tenaciousness to be able to see it through, because those people are watching it for it to fade away, and they'll sense it if you're not really engaged and tenacious about it.
Thank you.
I would say to listen to your staff, ask for input. Do not be afraid to admit that you made a leadership mistake. I had to really swallow my pride. I thought we had a great plan. Our initial strategy wasn't successful, and as we envisioned, and so we had to change that strategy. And our staff are realizing the benefits of the system now and are anxious for more capability and documentation automation. Those are probably the main things, just listening.
I resonate with all of those comments, you know, from including the patient in the design. How novel is that? You know, to really think about including the patient in what we're doing for the patient to be included. That is profound in its simplicity. The discharge process, I was recently a patient myself, and You know, I am probably about as activated as anyone is, which is not very activated when you're talking about your own patient, when you're talking about your own care. And what you said was exactly what I did. Literally, you know, I went to a hospital where people didn't know me, so it was, I didn't get anything extra, that's for sure. And sorry. And when it was time for me to go home, I literally got the stack with all of the sheets run off, and it was all put in that little plastic bag you get, you know, with your clothes and the little toothbrush and the pink little bin you got, and there's your discharge instructions, and that thing literally sat right on my kitchen counter. I mean, literally, to the story you told, I put it down. I couldn't tell you to this day what those papers said. And I don't think that my story is any different than anyone else. I'm not going to sit and read 10 pages of paper. I'm just not going to do that. But if you could show me a video in 2 to 3 minutes that probably will capture my attention, and then someone comes in and talks with me about that, it's a very, very different scenario. You know, and I would say that in terms of the tenacity needed and the humility that's needed in this process, very, very important. We have grown as a facility at Celebration. We added on about 65 beds, and with that brought on, probably we netted about 200 new faces to our campus, and had to add an entire level of leadership. And guess what? None of them knew about the journey. They didn't know about how we wanted to activate patients, and we had to make sure we had a process in place that all those new people got on board, but we didn't do that very well. We weren't systematic, we weren't organized, and so now we're seeing the results of that, which is some slippage in what we've done, and it's become a tactic or a task for some of the staff, and not really something that is a part of the care that they give. And so you're never really there. And I think that's something, no matter how great you are, you're never there. We always want to do better for our patients. And if you don't want to do better for your patients, then you probably shouldn't be in the field that you're in now. And so we want to make sure that we're doing better, but I do think that tenacity, the enthusiasm, and being able to say, we're not doing this right, let's go back and regroup, is very, very, very important. So if you enjoyed the panel discussion, show them by your attitude and enthusiasm that they were fantastic.